Hello, everyone. Thank you so much for being here today. While we allow a few seconds for everyone to join, please feel free to share through the chat who you are and where you're watching us from. My name is Paola Diaz, and I am the Outreach and Engagement Manager for the Hispanic Latino Behavioral Health Center of Excellence. Today's webinar is titled Driving Change Through Policy, showcased by the Hispanic Latino Behavioral Health COE Public Policy Academy. But before we begin, I wanted to let you all know a few housekeeping items. To hear today's event in Spanish, please go to the Interpretation tab on your Zoom panel and click Spanish. You can also mute the English speaker's voice by clicking Mute Original Audio. Para traducción simultánea a español, presione la pestaña de interpretación y luego presione español. También le aparecerá la opción de silenciar el audio original. Now, today's event is being recorded and will be made available publicly through our website and other media channels. For today's webinar, all participants will be muted. Please make sure your computer speakers are turned on and up to hear today's presentation. If you're having any technical issues, please send a message to the Hispanic Latino Behavioral Health COE on the chat box. If you have a question for our presenters, we ask that you use the question and answers chat box that you'll be able to see on your control panel. We will be sharing a copy of today's presentation in PDF format through the chat box. And we will also make a copy of today's presentation available to be downloaded through our website. You can find it under the name of today's event. A recording of today's webinar will also be posted on our YouTube channel. Now, once we complete the webinar, please complete the evaluation. This evaluation will help us know more about your opinion and thoughts about this presentation and what other topics and training would you like to see offered. A link to the evaluation will also be shared through the chat, and you can also scan the QR code at the end of the presentation to complete it. You will receive a certificate of attendance by email approximately 1 week from today. Please remember to check your junk folder just in case. The mission of the Hispanic Latino Behavioral Health Center of Excellence is to advance and support the sustainability of behavioral health by promoting community-driven, culturally grounded, and person-centered prevention, treatment, multiple pathways of recovery, and recovery support for Hispanic and Latino communities. And we strive to accomplish this mission through the development and dissemination of culturally informed, evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health workforce that serves the Latino communities. Now, at this time, I'd like to turn it over to Dr. Cristina Rabadan so she can introduce herself and begin the presentation.
Thank you very much, Paola. Welcome, everybody. Bienvenidos. So today we are going to have a very, very interesting webinar, probably one of the best that you have heard this year. I know it's going to be long, but what we want is for you to be also engaged. So I am Cristina Rabadan Diel, and I'm going to be the moderator of today's webinar. We have 3 panelists, a representative from the state of Georgia, a representative from the state of New Mexico, a representative of one of our students who work with the state of North Carolina, and another student who work with the state of Wisconsin. We are going to have the students' reflections, and you will understand why I'm referring to students. And then we're going to end up with questions and answers from the audience next. So just as a form of presentation, of an introduction for myself, so I am a bilingual subject matter expert, particularly on substance use disorders, with a special emphasis on opioid use disorder. I have worked for over almost 4 decades in different areas from evidence-based research and health policy, spending over 2 decades at the National Institutes of Health at the NIH, as well as the Director of the Americas at the U.S. Department of Health and Human Services. I have had the privilege to work with the interagency as well as other multilateral organizations such as the Pan American Health Organization. I'm a former George Washington University professor, and I still lecture because I really love interacting with the students, in particular in other institutions like Johns Hopkins University School of Public Health. When it comes to behavioral health and Latinos, I've been involved really most of my career in that. And I have had the privilege also of serving in multiple advisory boards, including the SAMHSA National Advisory Council, and work, as I said, with multilateral organizations. I have had the privilege to work and serve as a consultant to the Hispanic Latino Behavioral Health Center of Excellence, and being one of the leaders of their Public Policy Academy, which is what we are going to be talking to you about. But so you probably hear this accent, right? So I am originally from Madrid, Spain, and I have lived in the United States for almost 40 years. And no, I did not come as a child. So I actually came to marry my husband, believe it or not. So I love music and hosting at my house in Washington, D.C. And many of those who know me already had been at my house. And I think my paellas are not too bad. I also am a proud mother. So I had two sons, Alex, my youngest, who is an LA trained actor living currently in Madrid, and my son, Jonathan, who was a construction manager who lost his life at the age of 28 to fentanyl poisoning. So behavioral health is very personal to me. Next one, please. So what are we going to talk to you about, right? So we're going to talk about a public policy academy that was launched under the Center of Excellence through SAMHSA funding that we decided to call the initiative Poder, right? So advancing Latino behavioral health in the United States. Poder stands for policies for outreach, data, educating through reform. Next. So before you hear all of the presenters, I think it's important that we all get on the same page and understand what public policy is. So public policy is the avenue through which policymakers and practitioners work to address many of the society's more complex challenges. So that involves actions and decisions made collaboratively between governments and institutions to tackle public issues like advancing shared economic growth, access to high quality healthcare and education. What is important to note is that everyone, from politicians and civil servants to lobbyists and industry representatives, are involved in public policy. So all of us, that means all of us, right? So all of us, those individuals, strategize and come up with tactics and tools to push their proposed policies through. Next. Something that is very important, and that's why I'm stressing the importance of all of us understanding what policy is that many people relate directly policy with law. And although they are interrelated, they are very clearly different. So the law is a system of rules enforceable by government institutions, and they're focusing on legality and structure. So they're rules. While policy are guidelines or strategies adopted by organizations to direct decision, prioritizing flexibility and intent. While laws are passed by legislative bodies and interpreted by courts, policies are often developed by organizations themselves and can be adjusted or changed if needed without any legal proceedings. And I think that that's something very important. This particular second point is very important because it really makes the essence of the difference between law and policy. Laws are enforced by states, while policies are implemented by organizational management, right? From those organizations that might have developed. And finally, laws are generally applicable to all individuals within a jurisdiction, while policies are specific to organizations, institutions, or certain groups in a population. Next slide. So, what is this policy academy about and what is it responding to? So, I am sure that this data that I'm presenting here is very familiar to the majority of you. So we have really seen a large increase of Hispanic population in the last couple of decades. You can see on the upper left that by the year 224, the US Hispanic population has reached about 68 million people. When you look at the population growth in general, at the bottom, right below that one, you can see that the Hispanics made up more than half of the total US population growth from 2000 to 2024. Just in 25 years, the share of the total increase, as you can see by the graph, was 56%, way more than Asian, Blacks, whites, and other races. Now, something that is important to also know here on the right, on that pie representation, is that most of the US Latinos are US citizens, and surprisingly, many people don't know that fact. As a matter of fact, 79% are US citizens. Of those, about 45.4, which is about 67%, are US born, and the other 13% are immigrants that are US citizens. So what does this mean? What it means is that in the last few decades, we have seen a tremendous increase of Latinos, even in states that were not traditionally hosting large numbers of Hispanic Latinos. And as a matter of fact, and as a result, what we need is to start developing specific behavioral health programs that address the needs of those increasing populations. Next slide. And that is how the Public Policy Academy came to be. So the Public Policy Academy is part of the Hispanic Latino Behavioral Health Center of Excellence, which, as we said, is funded by the Substance Abuse and Mental Health Services Administration, SAMHSA. The goal of this academy is to expand the behavioral health workforce for Hispanic and Latino communities to bridge the gap between the behavioral health needs of the population and service providers. Therefore, the purpose of this effort was to establish a policy academy that convened state teams nationally or within a region in a state to do in-depth work on crafting policies and strategies within states to address the behavioral health needs of their Hispanic Latino population. So we created this Public Policy Academy 2025, which really was aiming to bring together relevant stakeholders. And by relevant stakeholders, we are not only talking about state health departments, we are also talking about community-based organization, subject matter experts, as of course the Center of Excellence, but also a critical workforce, which are the future leaders of Latino behavioral health, which are students. And collectively, we wanted to address the behavioral health needs of those populations through policy development. Next slide. So this is really an attempt to make an organizational chart of all of the stakeholders involved. And all of those are the ones that have comprised the Public Policy Academy 2025. So obviously the focus was on the states. And at those states, we had representatives of the states of Georgia, North Carolina, North Dakota, and Wisconsin. And in those teams, they came in not only the health departments, but also with community-based organizations, academicians, and other non-state holders. Realizing that we didn't want to reinvent the wheel, but also that we wanted to draw from experience of other states who might have had similar challenges and may have had come with creative solutions and policies, we invited to the Academy to 4 states and the District of Columbia to join us to support the entire enterprise of the Policy Academy. And those are California, Connecticut, Maryland, New Mexico, and Washington, D.C. obviously, although we are a very experienced team, we don't know it all. So recognizing that there were going to be issues that we really were critical for the effort we were making, we needed to bring in also subject matter experts in particular topics that the academy at large might be interested in. You had, of course, to support this whole enterprise, the terrific team of the Center of Excellence. And then, last but not least, are the students. As a former academician, I love always interacting with the students because one learns so much from them. We got extremely fortunate and we selected 10 students for this academy. These are all Latino students. It was really a fierce selection. Absolutely brilliant. They all were in different stages of their professional growth. They were all students from universities pursuing different levels of degrees, either bachelor's, master's, or doctorates. But all of them were in subjects that were related to behavioral health. And they were very committed also to Latino behavioral health. And you are going to hear from a couple of those students, and also we'll have a segment where we will engage a little bit in a question and answers of what this experience meant for them, right? Next slide, please. So how did we do this? So we created this community, and what we knew that the goal was to try to identify what potential policies will be useful for those states to address some of the most pressing behavioral health needs of their Latino populations in their states. So we use the CDC policy process to guide us. And for many of you, this process might be familiar. And if not, I invite you to go to that link to learn a little bit more about it. So as you can see, the CDC policy process has different elements. Problem identification that clarifies and frames what is the public health problem, right, in that particular state or community. The policy analysis, which we use quantitative and qualitative methods to identify potential effective and efficient policy solutions, and then the strategy and policy development. At that time, which was really getting the policy adopted basically and put it on paper. We stop there because the rest is really in the hands of the states to move that forward. But that was a tremendous exercise by everyone. Next slide. So I'm going to stop here, and I'm going to invite Rachel Holloman from Georgia, who was representing one of the states that received some of that technical assistance. So as a brief introduction, Rachel currently works for the Georgia Department of Behavioral Health and Developmental Disabilities as the director of the Office of Federal Grant Programs and Suicide Prevention, and has worked in various roles within the department since 2016. She has a master's degree in clinical counseling psychology and is a licensed professional counselor. She has been providing services in the field of behavioral health for approximately 2 decades. Some of her past experience includes supervising a community support team in rural communities, right? That's an area where many of us are dealing with, particularly when it comes to our Latino communities. So she has experience in that, providing leadership as the mental health director of a DJJ Regional Youth Detention Center, supervising an intensive family intervention team, as well as providing services in a private capacity for individuals involved with DJJ and the FCS, and assisting rural farmers in understanding, applying for, and receiving the much-needed grant funding following natural disasters. So Rachel has spent her entire life both living and working in rural communities in Georgia, especially South Georgia. Rural mental health services and suicide prevention services are passions of hers. So I'm just going to pass the baton to Rachel, who is going to show you and share with you her experience and the experience of Georgia in this effort, collective effort in our Policy Academy. Rachel, welcome.
Thank you. Thank you so much for having us. Next slide, please. Georgia was very excited to be involved with this Policy Academy and this policy analysis. And one thing we really wanted to do is address the Hispanic Latina behavioral health needs in Georgia. Next slide. We included this picture, this slide of our team because it was truly a collaborative effort. While I'm here today representing DBHCD, I could not have done it without my partners within the department, our partners within the community, and of course our students. I could never praise our students enough for the help that they gave us to get this done in the time frame that we did. Next slide. So let me tell you a little bit about Georgia. So Latinos make up approximately 11% of Georgia's population. And so we have some demographics there on this slide for you. I really want to notate that one thing we found in Georgia is that Georgia's Latino population is notably young. So we have a median age of 26, which is a full decade younger than the state average of 36. And then one of the other things that we really wanted to make note of is that around 30.4% of Latinos in Georgia are uninsured, which is compared to the national Latino average of 17.6. Next slide, please. So what's our current situation in Georgia? What does it look like right now? Right now, we know in regards to mental health challenges that suicide is the number 7 leading cause of death for Hispanics in Georgia. One of the other things we are aware of is that there's limited access to health services. Georgia ranks 47th out of 50 states for access to mental health care. And then there's also a behavioral health workforce shortage. So fewer than 100 licensed Spanish-speaking mental health professionals are in the entire state of Georgia. Next slide. So given the growing Hispanic Latino population, participation in the Hispanic Latino Behavioral Health Public Policy Academy was very critical for us. And some of the things that we really wanted to work on as part of this policy academy was to, number one, address gaps in access and workforce capacity. With extremely limited bilingual and bicultural mental health providers, many Hispanic Latino Georgia residents lacked accessible behavioral health services, which leads to underutilization and poor outcomes. In addition, we wanted to support youth facing growing mental health risk. So Hispanic Latino youth in Georgia are particularly vulnerable to mental health challenges. Among this population, about 49.7% reported feeling sad or hopeless almost every day for 2 weeks or more. And then we also wanted to build trust and leverage our community resilience. We wanted to partner with trusted community organizations and foster long-term behavioral health improvements. Next slide, please. So we actually, our framework for methodology is we actually chose 2 things that we really wanted to address as part of this policy academy and then be able to further that after the policy academy. So our number 1 problem identification was our workforce shortages. 72% of Georgia counties are mental health professional shortage areas, not just for the Hispanic Latino community, but just workforce shortages as a whole. There are limited access to bilingual and bicultural providers. Less than 4% of our nurses and physicians identify as Hispanic Latino. Our provider to population ratio can be as high as 1 per like 15,000 residents in some areas. And we really have limited culturally tailored in Spanish linguistic availability for services. Next slide, please. The second problem we really wanted to do is we identified is our gaps in data collection. So what we found as we were doing this is that DBHD providers really lack disaggregated ethnic and language data. And without detailed data, needs cannot be fully identified. So we really don't know what we're working with until we really get this data collection in the state of Georgia. This gap in data collection prevents measurements of service gaps and targeted interventions. and it also contributes to ongoing disparities in access and quality of care. Next slide, please. Here is just some more of our framework. You'll have the slides, so I'll let you read this. But basically what we did is we started looking at the options that we had for policies, what that description, you can read what the description was, how we determined it would be in the state of Georgia. And then we did everything based on a feasibility scale. You know, what's the feasibility? What's the cost? What can we do to actually move forward? We wanted to make sure as leaders for the state of Georgia with our community partners as part of this policy academy that we were really going to work on things that we felt like we could move forward as after the policy academy was over. Next slide, please. And so what did we decide to do? So that there were a couple of things that we really wanted to move forward in the state of Georgia. Number one was our bilingual peer certifications and workforce data. For our bilingual peer certifications, we wanted to make sure that we did our CPS and CARES in Spanish. And what that means for us in the state of Georgia is that it was to develop curriculum and recruit bilingual peers. We want to establish that certification and credentialing process. And then we want to secure funding and Medicaid reimbursement. And we identified the stakeholders as well that we need to bring to the table. The great thing about this timeline is it's actually short term. We have actually already started. I know Christina is going to be really excited to hear this. We've actually already started moving this forward with some of our key stakeholders. I actually had a meeting today on a possible new stakeholder that wanted to join this movement as we move this forward. And then the other thing we really want to do is track and report this bilingual workforce demographics. We want to create and distribute statewide surveys, standardize data collection and reporting, educate staff on the importance of data tracking, require disaggregated ethnicity and language data from all DBHCD providers. And again, this was a timeline that we felt like we could turn around in a short time frame. And so something that we definitely wanted to move forward in the state of Georgia. Next slide, please. So what were some of the challenges and limitations to this? Number one, first and foremost, no different than there's a workforce shortage in the state of Georgia for our Hispanic and Latino workforce, is also across the state of Georgia. And so the bandwidth of staff, given competing priorities, it was a challenge. Potential Medicaid limitations. Georgia is not a Medicaid expanded state, so we do not have Medicaid expansion in the state of Georgia. And so there were some concerns there. And then the funding to support these initiatives. Next slide, please. So just kind of summarize it all up. So what was our why? What was our how? And then what is our what? Like what are we doing moving forward? So our why, we recognize in the state of Georgia that there was a need for specific policies for Hispanic Latino behavioral health in the state of Georgia. We know that we have a significant statewide shortage of behavioral health professionals. We know that there are limited availability of culturally tailored behavioral health services. We know that there's gaps in data collection on the current bilingual, bicultural behavioral health workforce. And we also know that these barriers affect Hispanic Latino communities' ability to access and engage in care. So how did we do this? What kind of approach did we use to develop policies? We actually drew a lot on Yes, we actually drew a lot on Dr. Mancini's prior policy work and research. Dr. Mancini was one of our community partners that came to the table and has continued to help us move this forward. We incorporated student recommendations from literature reviews and data analysis. We reviewed examples from model states where they implemented successful, relevant strategies that we thought that we could also use in the state of Georgia. And then the policies proposed. We proposed two policies actually as part of this academy. One was to develop and implement a statewide bilingual enforcement certified peer specialist and certified addiction recovery empowerment specialist. And the other was to track and report on the bilingual workforce across Georgia. Next slide, please. So what are our next steps? So for the first policy, develop and implementing a statewide bilingual endorsement for CPS and CARES. Short term is planning and preparation. And we've actually already started this process since we ended Policy Academy in September. So part of that is requesting the curriculum from our Georgia Mental Health Consumer Network and GC4R, identify appropriate vendors to translate curriculums, curriculum translation and adaptation, and then also meeting with the Office of Medicaid Coordination to discuss feasibility, the process of adding this credential, the modifier. Georgia actually leads the way and has for several years in multiple decades in regards to our certified peer specialists. And so we really want to continue to do that moving forward. We want to outline policies and procedures for this credentialing process and then find funding to support the work. And then as we go on into medium and long term, medium term is really looking at that training infrastructure and what that looks like, identifying that first cohort, developing the trainer, hiring the bilingual staff. And then, of course, implementation, which is, adapting that established certification and credentialing, working on that Medicaid reimbursement, adding those modifiers for services delivered in Spanish or by endorsed bilingual CPS and CARES professionals. And then long-term is outcome and evaluation, tracking participant outcomes, getting their feedback, really understanding about the implementation and how that's going, and then tracking the actual number of Spanish CPS mental health professionals as well as CARES. Next slide, please. And then we're going to also look at the next steps for policy 2. And this is where we were going to create and distribute a statewide survey to assess the size and demographics of Georgia's Hispanic, Latino, and bilingual behavioral health workforce. Short term, we already have our data specialists working on with our community partners on this team, developing survey goals and key questions, reviewing the little bit of existing workforce data collections that we have, identifying the platforms for survey distribution, and then, of course, developing this survey and translating into Spanish. And then as we go on into medium term and long term, what are we looking at as we continue this process? Again, we're looking at implementation of this, actually the survey distribution and promotion, monitoring the response rates by region and provider type, and then evaluation, analyzing the data, identifying the key gaps, creating this dashboard or map to report findings across the state of Georgia. And then long-term, we're looking at this ongoing tracking and integration. What does this integrated bilingual workforce look like, and getting that data collection? What are we looking at with state Medicaid and contract requirements? And then what are we looking at as far as the workforce overall? Next slide. And then that is the end for me, Christina, but I know you're excited to hear that we're actually already moving forward with our CPS CARES and what that looks like. I was so excited to be able, when I literally had new partners coming up to me today and having meetings with them, I was like, oh, Christine, this is perfect timing. Christina's going to be so excited.
Well, you know me very well, Rachel. Thank you. Thank you very much for this terrific presentation. And for the audience, if you do have any questions, please drop them in the Q&A box. We're going to do that for every presentation. But then at the end of the webinar, we'll also save some time in case you have general questions. But while we're waiting, in case there are any questions to you, Rachel. So thank you indeed. You know me very well. I was just like, oh my God, this is amazing. But I have a question for you because you were one of those states that joined the academy in comparison a little bit later than others. We had some difficulties because of changes, obviously, and the timing for us was a little bit of a challenge. But you definitely came in and hit the ground running in a way that you should really sign up for the Olympics, because it was incredible and everything that you've done. So my question to you is really maybe an operational question in general. Now, from your perspective, clearly you have been very successful. You already know what you want to do, where you're going, and you are moving forward. In your opinion, what was the critical elements for your success? What was within the Policy Academy? What were things that you found, wow, if we hadn't had that, we wouldn't have been able to get that far? If any, if you had none, that's fine.
Well, no, I think one of the things that we were really able to do with the Policy Academy is it forced us to take a harder look at Georgia and what our current landscape was. And then as we did that, we were able to put a presentation together for the for executive leadership in the state of Georgia within DBHGD. Luckily, you had several members of that leadership.
Yes, I remember.
And so it actually really helped us to be able to give the call to action for the state that this was something we needed to get behind and move forward. It was something that we were aware of. Like, we knew this, we'd had partners come to us about this, and knew's probably not the right. We were already starting to have conversations around this. We had already started talking about the need for a gap analysis in the state of Georgia for cultural linguistic services. And this just kind of gave us the push and the opportunity to really do a deeper dive and decide, okay, how can we move this forward? And that was something we were very intentional with the Policy Academy. I think you remember we came out with all these ideas. Dr. Mancini gave us this amazing report, which significantly helped us get some eyes into that community and what we were going through. But at the same time, from the State Department's point of view, we were able to say, okay, we want to make we don't want to just do this Policy Academy and it stop. So we were really looking at what can we do? Where can we make a difference? What already aligns with some of the priorities that we have in the state of Georgia with DBHGD? And these were the two that we were able to align with and actually work with some other, and actually kind of integrate into some other work we were doing in the state. And so I think that's what's going to help us continue to move it forward.
Thank you, Rachel. And one of our students, Isabel Figueroa Fernandez, in the question and answer box, she's in that line also. She says, I would love to know what was most meaningful for you during this academy, professionally and personally.
Oh, goodness. Personally, probably one of the things, and I would probably say professionally as well, we got really close with Sur Familia, which is our largest Latino serving provider in the state of Georgia. We've since gone to several of their events, and we're continue to build that partnership. And so I would think that really gave us a different way of looking at things. It gave us a different perspective. I've developed a great friendship with Belisa. And so, and now we've also got a professional relationship with that moving forward. And I think that was probably one of my biggest takeaways, to be real honest. I knew we had worked with the provider in the past, but in very limited capacity. And so to be able to have them to the table and have such an integrated conversation with her organization, and then getting to be boots on the ground with them some after the policy, after the Policy Academy, when we came back to the state of Georgia. And really, that has made a huge difference to me. That was very personally and professionally very important to me.
Thank you very much, Rachel. Actually, it was very clear to us that even though states and CBOs work closely, sometimes they don't have the space to really listen to each other because of competing priorities, as well as to develop bonds moving towards a common goal. And I think that that's probably one of the unintended consequences, which are the positive ones, that are coming out of the Policy Academy, besides creating really that community of states and different stakeholders. So thank you for that, Rachel. Congratulations to Georgia, and please don't be a stranger. Just keep us posted on your terrific proposals. Next slide, please. Okay, so the same way that we've had Rachel illustrating the work of one of those states that were on the receiving end of the technical assistance, We now welcome New Mexico and Travis Leyva, who is the Board of Health Director of the New Mexico Department of Health. And they, his department and himself were part of that supporting state network that we had created as part of the Academy. Next slide. So Travis Leyva serves as the Director of the Office of Board of Health for the New Mexico Department of Health. Mr. Leyva functions as the primary liaison and point of contact between the New Mexico Department of Health and the public health authorities in the state of Chihuahua and Sonora, Mexico. In addition, Mr. Leyva is the New Mexico Department of Health Health Secretary's delegate to the United States-Mexico Border Health Commission. As the Health Secretary's delegate, Mr. Leyva works closely with the Southwest Public Health Division in all 8 of the state's counties on the U.S.-Mexico border. He earned a Bachelor's of Science in Public Health from New Mexico State University and a Master's Certificate of Business Administration, Real Estate Law from Kaplan University. He has been published for his work with a 2006 Binational Border Influenza Surveillance System between the U.S. and Mexico. He also has been recognized statewide for his creation of the intervention tool iHeal, Integrated Health Education for Addictive Lifestyles, and was the 2021 recipient of the New Mexico State University Most Distinguished Alumni Award by the Health and Social Services Department. Congratulations, Travis. He has worked for the New Mexico Department of Health for 21 years, 12 over those years as the Regional Disease Prevention Program Manager. Welcome, Travis.
Thank you, Christina. Thank you. I appreciate the introduction. Next slide, please. So yes, thank you again for participating. The last 6 years, I've been the delegate to our health secretary here for the U.S.-Mexico Border Health Commission, like Christina said. And with these relationships, it's how I became introduced to the Hispanic Latino Behavioral Health Center of Excellence. So thank you, to COE and Christina and everyone for having me participate with you all. It's been a pleasure. Like you see here on the screen, in New Mexico, we participated as with the Academy as a supporting state. I think one of the biggest tools that I was able to offer to the Academy was how we were able to support our public health work around community health workers, especially here along the border. I'll talk a little bit about demographics here in a minute, but our community health workers are truly our extension of public health services in our state. And recently, we've also been able to work with our community health workers in Medicaid reimbursement throughout the whole state. So that's been huge. And one of the major things that has happened recently, as we all know, funding has been taken and or given, and it's all over the place. And one of the things that I'm really proud of is that the work of the community health workers along our border, it hasn't stopped, regardless of funding. It's a great program, they're great workers for our public health offices as they continue the work and help provide services to the community. So it's been great. Next slide, please. So a little bit about what we do at the Office of Border Health here in New Mexico. So like I mentioned before, we support the public health priorities along the southwestern border, and that borders up to El Paso, Texas, Chihuahua, Mexico, and Sonora, Mexico. Here in New Mexico, we have 2 major port of entries with Mexico, one in Santa Teresa and the other in Columbus. Now, Santa Teresa is probably the biggest port of entry that we have, but it's also one of the biggest commercial port of entries for the state and also the El Paso region, the Paso del Norte region. But in addition to our Las Cruces El Paso connection, we have other major little sister cities that we work and strive to improve the health status of these communities living in these areas for sure. You'll see a nice picture there of our group that we work, and again, our mission, our role is we just fill the gaps. We fill the gaps of our public health priorities with our public health system, and find the needs of our community and make sure that we can bring those services to help those needs. Next slide, please. So a little bit about the demographics for the Hispanic Latinos in New Mexico. As you can see from data from 2021, New Mexico had the highest percentage of Hispanic Latinos of all the U.S. states. We currently have a population of 2.13 million people in the entire state of New Mexico. So although we are a big land state, we're not heavily populated like many of our other border states. Out of the 2.13 million people, there's about 1.1 million living in the Albuquerque area, which is in central New Mexico. So here along the border, our biggest county is Doñana County, and that has about 220,000 individuals. So I say that, but as we all know, health in general does not have a border. And when I talk about the Paso del Norte region, the Paso del Norte region is made up of West Texas, mainly El Paso County, and also, of course, Ciudad Juarez, and then also, southern Doñana County, southern Luna County in New Mexico. In that region alone, we're looking at about 2.4 million people. So just in that region, if you cut that region out, and sorry, I don't have a nice demographic of that, but if you cut that region out, there's more people living in this Paso del Norte region than the entire state of New Mexico. But as you can see here, the Hispanic Latino ethnicity by sex and age, you can see the majority is 18 to 44-year-olds. Next slide, please. So one of the things, as a contribution to the Academy, as a supporting state as well, it has been our work, like I mentioned, with our community health workers, and also the development of a Medicaid toolkit for community health workers that, providers can utilize in our state system for community health worker services. This was led by our Office of Community Health Worker program, which is within the New Mexico Department of Health. And next slide, please. So as you can see, probably one of the biggest things was in order to start seeking reimbursement for services provided for our community health workers, it all started with legislation. So as you can see here, it's probably small, you can't see it, but when you get the presentation, you can zoom in on it. But it's our letter of support to the Center for Medicare and Medicaid Services that was approved by our healthcare authority within our Department of Health that allowed our legislation to approve, certain services in clinical settings for the community health workers along our state to be reimbursed. Next slide, please. So once approved by our legislation and the Center of Medicaid and Medicare Services, a plan and a toolkit of how to become a Medicaid reimbursable community health worker in New Mexico began. Our Office of Community Health Worker program created a certification program that certifies all community health workers and also provides specialty certifications in order for the community health workers to bill Medicaid for services in the clinical setting. Now, as you can kind of see this algorithm, we have around 400 CHWs in our state, many of them with tons of experience, lots of training and education behind it. But regardless if it's someone who's just starting as a community health worker or also maybe have been a community health worker for 25 plus years, we invite them into our Department of Health certification program. With that, due to legislation, that's what is going to get them certified in order to be able to get reimbursed through Medicaid. The Office of Community Health Workers program has developed an online training so that folks from all over the state can get online and take their certification program. And then once they're certified, then they go through the system, the Medicaid system, in order to get their NPI number. They also get their Medicaid provider enrollment. A lot of our managed care organizations work through that. And then there's also training in that not only the Department of Health, but also CMS, they provide for billing and billing processes, and to ensure that, that everything is adequate and everything is as in line with the clinic that they're working for. And then, of course, goes to the Medicaid reimbursement. Next slide, please. So as I mentioned before, the toolkit that I shared with the Academy and all the states, it is online, and you can definitely just Google Community Health Worker New Mexico Medicaid Toolkit, and it'll pop up. And, in New Mexico, many of our higher educational institutions, fairly qualified health centers, private providers, they're all using this to bill Medicaid for their services. Here with, the Department of Health, like I had mentioned, we had about 16 community health workers contracted with the Office of Board of Health. We had them in all of our public health offices that were working with our WIC program, our family planning program, STD, HIV, and TB programs, and even our harm reduction program, which provides syringe exchange, naloxone education distribution, and also Suboxone, which is MOUD treatment. If you rewind back earlier this year, we were trained and ready to go. We had everything ready on April 1st to start the billing for all these services for all the 16 community health workers. And unfortunately, the funding was lost March 24th, right before we were able to start doing it. But, since we had everything documented, and I was able to share with the states in the Academy, it was a tool. The process of how to get there, how to do it. Now, obviously, we didn't get to pursue it, but we're working on it. But but one of the biggest things I think that we miss, and I can tell you that a lot of our clinical services tells us that they miss, is our community health workers were the ones really finding folks in rural areas. They were difficult to reach. Maybe they were finding folks that didn't have smartphones or laptops or computers or, internet access. So they were out, 2-3 hours away from their public health office, finding folks out in the community and bringing them into our services. One of the other things that we've been able to do throughout the state is get mobile clinics, working out of our public health offices, and, sometimes driving out into a rural area and, setting up shop to provide, let's say vaccinations or maybe syphilis screening or something like that. It's all fine and dandy when you have your stuff there, but if people don't know about it, they don't show up. And that's what the community health workers brought to the table. They were out in the community, 2 weeks, 1 week before the events or before that mobile clinic went out there, and they were able to bring folks there because they're trusted members of the community. So, we missed that, but it's still happening, just not as big as a scale as it was earlier this year. But, we're really excited that we had the ability to utilize our community health workers in such a way that benefit not only the community members, but also our public health workforce as well. But, the can-do attitudes, I have never, ever, knock on wood, I've never had a community health worker tell me that they couldn't do something. Because even if there was barriers, they were always sitting down saying, all right, let's figure this out. How can we, work through this, or how can we partner up and get this done? Because if this is a public health need, then we need to address it. And that's always been the attitude, and it still is to this day. But one of the things that I'm excited to announce is that right now, I am working with the Office of Community Health Worker in getting a mental health specialty certification program. I learned so much being a supporting state, but I think I was a student myself. I learned so much from not only the students, but also from the other states and our partners through this academy, that I was able to bring a lot of information back to the table here in New Mexico and say, hey, look, this is a gap we're missing. Let's get this done. So, hopefully in a year from now, I'm invited back, and I'll definitely talk about what we're doing around mental health in our community health workers. So I'm excited to announce that. Next slide, please. Just some things that had mentioned before. We do have the 988 number like we do nationwide, but one of the things that our CHWs were doing in our public health offices and also in outreach was they were able to ask questions and also provide the mental and substance use referrals to our partners, especially along the border and in the Paso del Norte region. Because many of our folks, they may live in New Mexico, but their nearest doctors are 15, 20 minutes that may be in Texas, or they may be in Mexico. So, we've connected with those partners and we've been able to say, hey, look, we'll make the referrals to you all, but what services do you provide? And that way our promotoras and our public health staff, they know, and they can make those referrals in a timely manner. Next slide, please. So many of you may know of CCBHCs, which is our Certified Community Behavioral Health Clinics. These clinics are a type of an outpatient clinic that provides a comprehensive range of mental health and substance use disorder services. These clinics here in New Mexico, there's 6 of them. And one of them is located here in Las Cruces, New Mexico, which again is about 35, 40 minutes from the border, 30 minutes to El Paso. And again, these clinics are certified at the federal level based on the criteria, that ensure high quality, person-centered care. And just recently, our clinic here in Las Cruces has been able to initiate the 24/7 crisis response team. So, they're serving individuals regardless of their ability to pay, their location, their insurance status, everyone from those with mental illness to co-occurring disorders, substance use disorders, they're able to provide this service. So our mindset, again, thank you to the Academy here at the Department of Health, is we're looking to see how we, with our community health workers, can get that word out, because it's very difficult for individuals, especially Hispanic Latinos, who may not be aware or may not, there may be some cultural barriers. But if they know that these programs are available to address these needs, our thought process is that we want the community health workers to become subject matter experts in it, as far as the education piece, so that they can at least inform folks in the community so that they can get them to services. So, much like our CHWs did during the COVID pandemic, we're looking to really see if we could get this going with mental health and behavioral health needs in southern New Mexico. Next slide. And I think that's it. So thank you for the time.
Yeah, thank you very much, Travis. I actually had a question about, what was the Academy contribution to you, but you already have addressed that, so clearly this is really nice. And I think that, just, and you had made some mention to that, which was, your legislation that was passed as far as reimbursement for certain services when they were offered by community health workers. And I think that particular model, I have to say to the audience, really caught the attention to many of the members of the Academy, because I think that for all of us who work in Latino behavioral health, we recognize the importance of the community health workers because of what they can offer, and because they are members of the community really with a passion and a dedication to our community, and they are able to build trust. And I do remember being in New Mexico when that legislation passed, something that I did not say, and that is the reason why I actually reach out to Travis is that in a previous life, I was the HHS representative, the federal HHS representative of the Secretary of Health to the U.S.-Mexico Border Health Commission. And it was within my purview to oversee the 4 member states, the U.S. member states, among which was New Mexico. So I remember having all of this conversation and celebrations in the U.S. section of the Border Health Commission when that legislation was passed. And so we please, if you have any questions, yes, put them in the Q&A box. We are going to be moving to our next presenter, and as I mentioned, and I think that Rachel mentioned also how important the students had been in all of this academy for us. And so we asked them, 2 of them, to present their work with the 2 other remaining states, which are North Carolina and Wisconsin. So next slide, please. So I'm going to invite Joshua Villa, that was one of the students supporting the North Carolina team, to really present the work that they did. And then we are going to talk with him and later Jessica about their experience. So let me introduce you to Josh. He's currently a PhD candidate in educational leadership and psychology at Wichita State University in Wichita, Kansas. His research is centered on the development of a preventative program aimed at increasing mental health awareness among minority populations, with a popular focus on the effects of machismo on the mental well-being of Hispanic men. And I can tell you that issue about how we engage Hispanic men in behavioral health made it all the way to our final Academy in-person meeting, because that was a common question that all of the members had. So not only did we have a subject matter expert, but clearly Josh's contribution to that topic was instrumental. So through his academic and professional journey, he has always remained deeply committed to public health and advocacy for underserved communities. He's very passionate, I can tell you about that for sure, about identifying service gaps and working towards innovative community-centered solutions. His recent work has led him to focus more intentionally on rural areas with high Hispanic populations, where he really believes research, and as a scientist, this is music to my ears, can uncover critical insights and contribute to meaningful change. Helping his community has always been a core value in his life. He is a first-generation college graduate and the first in his family to earn a master's degree and pursue a doctorate. He's dedicated to using his education and life experiences to uplift others. And I can tell you that was very clear during the journey that we had in the Policy Academy. And he says that his involvement in the Policy Academy has further strengthened his ability to advocate, providing him with the tools and platforms needed to create lasting impact while progressing towards his professional goals. Clearly, Josh, you have been an amazing asset to the Academy, so the floor is yours. Next slide.
Well, thank you very much. Thank you, everyone who is attending today to learn about our work that we did with the Academy over the past few months. So my state that I was working with was North Carolina, so addressing Hispanic Latino behavioral health needs in North Carolina. Next slide, please. So just a little introduction of my team that I was working with. So Carolina from the North Carolina Department of Health and Human Services, Molly, the Director of Clinical Training with El Futuro, and then Isabel, my counterpart and ride or die hand that helped me the most when we were working on these policies, my other policy consultant fellow with the program, and then myself as well. Next slide, please. So the purpose of us working with this was to highlight the behavioral health disparities among Latinos in North Carolina and advocate for the policy-driven workforce solution, particularly through the creation of a community mental health worker, or CMHW, credential to expand culturally responsive and responsive care. So with this, it was basically just us looking at what we can do to improve and highlight the behavioral health needs and disparities that were going on within North Carolina. Next slide, please. So a little bit of context. So there was a rapid growth within North Carolina's population. So over 1.1 million currently are in North Carolina, and which is expected to double by 2050. There was a growing need for services. As the community grows, the demand for culturally and linguistic appropriate behavioral health care was rising. Major behavioral health disparities that we saw was Latino communities faced language barriers. They were limited to bilingual providers, high uninsured rates, and strong stigma surrounding the mental health. And then rural areas were hit hardest within North Carolina. So rural counties had the fewest mental health providers, making access even more difficult for Latinos and families outside major cities. But why does it matter? So without addressing these gaps, behavioral health needs will continue to rise faster without these being responded to or changed. So again, rural areas were the hardest ones that were hit within North Carolina. Next slide, please. So the participation of the Hispanic Latino Behavioral Health Policy Academy guided the approach for our look at this. So we looked at the CDC policy framework that guided this process. So the framework was used to ensure a structured, evidence-based approach to developing policy solutions that expanded our access for bilingual and culturally responsive mental health services. So we used the 5 key factors with it, which was to identify the problem, which was there wasn't enough bilingual or culturally appropriate mental health services in the state. The second one was to analyze the issue. So we looked at what's causing the gap and what resources are available. Third was to develop a strategy, which we created a plan to increase access services that respect language and culture. Fourth was to enact our policy, which worked with leaders and partners to turn into these plans into real policies moving forward, and then implement policy, which would be number 5, which was supported by providers in the system to make these changes happen. So the center of this process is community engagement and education to make sure that Hispanic and Latino voices guided every step with it. We also use the evaluation to track progress over time. Next slide, please. So problems identified with this. So there was a provider shortage. So 94% of counties lack enough mental health professionals, especially Spanish-speaking providers within North Carolina. Uninsured rates were high. So 31% of Latinos had no insurance, making care hard to access within areas of North Carolina. Economic stress, 22% live in poverty, pushing mental health needs to the background. High trauma exposure, people face trauma, crime, migration, arriving or unaccompanied minors. Poor mental health outcomes, so higher rates of depression, suicide, and substance use. System barriers, language, transportation, fears, and documentation status kept people from seeking help as well. And then need for culturally responsive care. So services that weren't really respecting Latino culture or language or lived experiences, making it harder to connect with individuals that lived within North Carolina. Next slide, please. So our main policy proposal was to create and fund community health workers by having them get credentials. Sorry, I'm losing words here. Build on existing community health worker certification within behavioral health needs training, enabled Medicare reimbursement. So giving them a faster pathway for this. Other strategies that we looked at was recruitment incentives for bilingual providers, licensure pathways, interpreter specialization of behavioral health, education pipeline from high school to graduate programs. So looking at how someone in high school can technically go into a program while they're in high school, if not getting ready to graduate, to become a community health worker. And then the workforce development of the HB 67 and community alignment. Those of you that are not familiar with HB 67, it is a law that enacts healthcare workers to reform to improve access to healthcare. The law makes it easier for healthcare providers, including physicians and physician's assistants, to get licensed. So it's faster licensures for doctors. So North Carolina has joined the Interstate Medical Licensure Compact, which lets qualified doctors get licensed in multiple states and make it more easily for a pathway for them. Expanded roles for PAs. PAs will have more of an independence for the first time, giving experienced PAs won't really direct supervision from a doctor. So that was one of our main policies. Next slide, please. So challenges and lessons learned. So broad community needs. So first, the range of needs across communities was extremely broad for mental health, housing, workforce, immigration status, language access, which made it very difficult to narrow down to a simple policy to focus without leaving anything out. We found data gaps, which faced different shortages, and there was no centralized system tracking on how Spanish-speaking or bilingual mental health providers currently existed in North Carolina, which limited the ability to make full data-driven workforce projections. Geographic disparities. This challenge in urban centers like Charlotte and Durham look very different from those in rural counties with no providers at all. It made it difficult to design a one-size-fits-all policy solution. And then policy instability. So another barrier for that was policy instability, state and federal priorities around workforce, Medicaid expansion, and immigrant access continue to shift, making long-term planning harder and sometimes politically risky to even execute. And then limited capacity. The work was done by a small team, all of us balancing jobs and education or school, which limited it deeply on how we engage with different stakeholders to conduct surveys or generate new data. So basically, it was all research-based and what we already know versus actually working within the community and moving forward with that. Next slide, please. So this was our timeline that we kind of came up with. So short term, which is 0 to 12 months, would be to draft policy recommendations into funding proposals. So example, trauma-informed interpretive training, educate policymakers on strong mindsets of North Carolina-based program findings, support community health workers' credential designs with North Carolina Community Health Workers Association, pilot the CMHW training with El Futuro's care model that they currently have. Next would be our medium term, which is 1 to 3 years. Partner with community colleges via the House Bill 67 to recruit bilingual human service students. Disseminate the community health workers training through technical assistance efforts. Prepare for Medicaid reimbursement by defining services, activities, and supervision models. And then lastly, our long term is 3 to 5 years and expand partnerships with the NCC HWA and universities to serve demonstration sites, with community health workers, integrate into Medicaid care funded models, and collect data to support statewide scale up in the policy integration. And next slide, please. So what I learned. So the Hispanic Latino Behavioral Health Center of Excellence Fellowship strengthened my ability to analyze behavioral health systems, advocate for culturally responsive policies, and build collaborative solutions to address disparities impacting Latino communities. So with this, I was able to look at different areas in different states outside of the state of Kansas, looking at how workforce development is executed in different states versus where I'm from. I got to look at policy analysis and advocacy and how we interact with one another, or how we look for different stakeholders to kind of fund our programs, and how we have access to care, and the systemic barriers and just different barriers in general that Latino or individuals go through when trying to access healthcare. The community engagement portion is a huge portion of mine because currently working within community engagement, it's something that I want to see move forward. And I feel like that is a strong stepping stone for moving forward within behavioral health, and how we can access different things moving forward within healthcare. And next slide, please. That's it. Thank you.
Thank you so much, Josh. I don't know if anyone in the audience has any questions for you, but since we're going to have a segment for you and Jessica, I'm just going to hold my questions. And if not, maybe we could just move to the last speaker. which will be Jessica Cruz. Next slide. Okay, so once again, we wanted to highlight the work that the states had done through the voices of their students that were assigned to that. So the last presenter is Jessica Cruz, who worked with the Wisconsin team. Jessica is a Master of Public Health candidate in epidemiology, a former school of mine, Milken Institute School of Public Health at the George Washington University. She is a first-generation Mexican-American, and she's very passionate about advancing health equity and improving the well-being of Hispanic, Latino communities across the United States. His work focuses on understanding how social, behavioral, and policy factors influence chronic disease and mental health outcomes in underserved populations. She's aiming to apply epidemiologic research to develop data-driven, equitable solutions that reduce disparities in obesity, diabetes, hypertension, and behavioral health, which is quite interesting, right? Because all of those conditions are very much intertwined. And sometimes it seems like in the behavioral health field, we don't put enough attention to high quality data that it is coming from epidemiological research. So that was one of the things that clearly Jessica had contributed to not only the Wisconsin team, but to the entire community of the Policy Academy. So as a fellow in the Hispanic Behavioral Health Policy Academy, she collaborated with Wisconsin policymakers and community organizations to analyze, revise, and craft policy recommendations to strengthen the behavioral health systems for the Hispanic Latino communities. This experience, she says, has deepened her commitment to bridging research and policy, which is very dear to my heart because that's been my career to a certain extent. So, and she plans to do that by using evidence to inform sustainable, community-centered strategies that improve health outcomes and advance equity at the local and state levels. So thank you very much, Jessica. So the floor is yours. Next slide.
Absolutely. Thank you so much for the introduction, Cristina. My name is Jessica Cruz, and today I'm very excited to share the student perspective on how the Wisconsin team developed policy recommendations to strengthen Latino behavioral health. Next slide, please. So here are the names of our amazing Wisconsin team. We consisted of leaders in the Wisconsin Department of Health, including experts in multicultural services, peer support, and state health planning. We also had representatives of Centro, which is a Latino nonprofit in Wisconsin, and of Noble Community Clinics. And of course, Frank and I were both students coming from different universities who served as the policy consultants / fellows for Wisconsin. Next slide, please. And now to give you a little bit more context on the situation in Wisconsin. Wisconsin's Latino population is 7.6% of the state's population. And in this map on the left, you can see that Latinos are often concentrated in the southern eastern region. Our research of the State Health Improvement Plan and then just general discussions that we had with the team informed us that stigma around mental and behavioral health remains a large barrier for the Latino community in Wisconsin. Many Latino residents unfortunately face a mismatch between the language that they need and what providers are able to offer. And a lot of that is driven by the underrepresentation of Spanish-speaking individuals in the mental health and behavioral health field. Additionally, there are very few training programs assigned for bilingual peer specialists. So just to give you some context and definition, certified peer specialists or CPS are individuals who have lived experience of mental health or substance use recovery and who are then professionally trained and certified to support others in this recovery journey. However, the reality in Wisconsin is that bilingual certified peer specialists, their work field is very limited, and the curriculum that they received is very recovery focused and not culturally tailored to Hispanics/Latinos. So as a student, this is where I contributed the most early on. I pulled together with Frank, pulled together demographic data. We reviewed the Wisconsin State Health Improvement Plan, and we summarized how these systematic issues affect the Latino population. Next slide, please. So this slide represents the roadmap we followed. First step was problem identification, second step was policy analysis, and the third step was the strategy and policy development that we stopped at. And from the student side, this framework really saved us because policy is pretty complex, especially not coming from a policy background, but breaking it into these easy steps made it easier to understand where we were and where we were going to next. Next slide, please. So now let's go on to the first step, which was problem identification. At first, the Wisconsin team had many broad issues, which included stigma, lack of services, language mismatch, provider burnout, so and so, but we quickly realized that we needed to narrow our focus down into something that was actionable and feasible. So through conversations with DHS, our team identified three main priorities. First, Wisconsin CPS training has very little prevention content. It mostly focuses on recovery, and this leaves certified peer specialists, less prepared to address risks before crises happen. Second, there are extremely limited bilingual CPS training opportunities. Right now, the only training center in Wisconsin that provides bilingual CPS training is Centro, and Centro is located in Dane County. It is in the southern eastern region of Wisconsin, so it's a good location to be at, but unfortunately, Centro only has the capacity and resources to train about 44 bilingual certified peer specialists a year, which is far below the demand, not to mention the geographic availability. And lastly, the CPS training is not as culturally affirming as we would like it to be. We all know how important cultural context is, especially with working with Latino families and Latino individuals, where stigma, family dynamics, and language all influence how people experience behavioral health. So while Wisconsin did have some culturally affirming continuing education credits, the core CPS curriculum didn't fully incorporate those examples or training approaches into its curriculum. And so this obviously results in peers feeling underprepared to support clients in ways that honor their culture and values and lived experiences. Next slide, please. So once we had our three problems clearly defined, we moved on to the next step, which was strategy and policy development. So our first strategy, our first policy recommendation was to add a prevention component to the CPS curriculum and for it to be culturally representative, culturally cohesive and aware. So our first strategy focused on strengthening this existing CPS curriculum and just integrating a little bit more content by having an advisory committee that could serve as experts. So in this advisory committee, we would recruit people from Latino serving organizations, faith-based organizations, community members, and other experts in policy and behavioral health to help us design a curriculum that is not only prevention-oriented, but also culturally grounded and relevant for Latino communities. And the second strategy was to expand bilingual CPS training availability. So this includes serving counties to identify areas in Wisconsin that are of high need, partnering with additional Latino community-based organizations to host trainings and to ensure that the burden doesn't just fall on Centro, and to secure more funding to train more trainers, gain more materials, and support participants. And so the goal here was to expand beyond the 2 annual cohorts that Centro offers and to make bilingual training more accessible statewide. And as a student here, I supported both strategies in several ways. So first, I researched the prevention curriculum that other states and nearby Wisconsin used. So we looked into Illinois and Michigan, and on top of other states that were nearby. We also met with the teams from New Mexico and Maryland to understand how they navigate prevention services and how they evaluate their programs, which served to be very useful for our conversations. We held one-on-one meetings with the Wisconsin's peer service coordinator to understand the feasibility of our policy recommendations and understand what would be a constraint to moving it forward. And of course, we worked closely with the team and with Cristina and Luz during our regular bi-weekly meetings to envision the implementation steps. Next slide, please. And now moving on to the challenges and lessons learned. Our team did face a few challenges, but those challenges really shaped our overall experience and really helped move us forward. So the first one I want to highlight was that it was hard to narrow our priorities. We did start with a long list of issues that ranged from stigma to workforce shortages, and we even looked at youth mental health at one point. So deciding which problem to prioritize did require a lot of discussion. But as students, this helped me and Frank understand that when it comes to policy, there is a lot of trade-off and negotiation that goes into it, and this was a great learning experience nonetheless. Our second challenge was that we did have limited workforce data, in particular to the bilingual certified peer specialists, and this was an issue because we wanted to know where those bilingual certified peer specialists worked, where did they serve, which communities they served, and if they're still doing it or not, just to give us a understanding on which exact regions in Wisconsin would need a certified peer specialist cohort in its region. So that was a little hard because we didn't have that data. And third, another challenge was that there was an uncertainty of the national climate, and this was a little bit concerning because of budget constraints. But moving forward to the lessons learned, I would say to the students and just to anyone who wants to be part of the academy next year, is to narrow your scope very early on. Trying to solve everything means solving nothing. So just hone in on something. So just honing in on a few priorities and working with that will produce meaningful change. Second, it is important to remain flexible because policies change, so do priorities, and new information keeps on coming up. So just being open to adjusting any approach and moving forward would really be useful for this academy. And third of all, and I would say this is my most valuable lesson learned, was to use all the resources that the academy provides. I, in particular, learned so much from DHS in Wisconsin, the academy leads, the student cohort, and our supporting states, and also the experts in behavioral health. And so asking those questions and leaning into those resources really made the process much more manageable. Next slide, please. Now, in terms of next steps, I'm very happy to say that our recommendations did not stay theoretical. Wisconsin did create an action plan to moving these steps towards implementation, and that includes piloting the prevention enhanced bilingual CPS training at Centro. It includes evaluating outcomes and participant satisfaction to see what needs more refinement and whether the participants of the CPS training feel confident in supporting the Latino community in Wisconsin. After that, we would integrate changes into this current state plan. So findings from this pilot would feed into updates for the Wisconsin State Health Improvement Plan. And lastly, we would advocate for continued funding so that we could expand the program, strengthen the bilingual workforce, and ensure consistency across the state. Next slide, please. And I just wanted to give a special shout out to the whole academy that I worked with. Luz and Cristina, they were amazing. They were amazing in this whole process. Their guidance provided structure. It helped us think strategically and ensure that what we had aligned with the policy process and what this academy required of us. Also special shout out to the student cohort, because being able to check in with the other students that worked with the other states really helped ground us. They all were going through the same exact steps as us. So having those spaces to talk it through just really built a strong sense of community. And also special shout out to the Wisconsin team, because they're the experts in policy and in their community. So I really appreciated that they treated us, the students, as collaborators and not just as students. And also the peer collaboration with New Mexico and Maryland was particularly useful, especially in our problem identification. And just hearing how they approach similar challenges just gave us an idea of what new strategies to think of and give us a better understanding of what would be feasible or not. And I put in graduate coursework, but I just wanted to, the only thing I really wanted to say with that was that I did come in with a small policy background through my coursework and research and community engagement. So I feel like those did serve useful into this academy. But yeah, this concludes my presentation. Thank you so much for allowing me to speak about my experience, and I'm open to any questions if there are any.
Thank you. Thank you so much, Jessica. It was very moving to hear how you really have walked us through the experience from the student's perspective, as far as, you know, some of the challenges and also some of the potential solutions. So again, you know, we are going to go to the question and answers at the end of this webinar, but we wanted to spend a little bit of time with the two students that have been presenting here. And in part is because when we started thinking about the Policy Academy and what were the critical elements, we realized that, and I can tell that because I've been, you know, part of not only being faculty, but also I have done my graduate studies in public health and others. And not necessarily the issue of policy is stressed enough for those professionals that are moving into the behavioral health field. Well, we realized that it is very important that that policy component is there. So we were aiming to provide and perhaps, you know, some competencies and some on-hand experience to those that will be the leaders of tomorrow. And also recognizing that one of the issues and challenges that we have in our Latino behavioral health field are workforce. So we wanted to take this opportunity to also give them the tools that were necessary for them to not only get them from their schools, their universities, but also from those individuals that were posed to do policies like the departments of health. What were their challenges, as Jessica had said, but also what are the partners that need to come into that dialogue. So Jessica and Josh just represent really the collective of the students. And I do know that there are some students that are also part of that audience. So if we do have some time, I would like you, the students also, as well as the rest of the audience, to either make comments or put it in the Q&A, and then you know, you can contribute to this conversation. So this question goes for both of you, Jessica and Josh, and some of you already have mentioned about some of the, you know, the challenges. But I want you to go into the personal level, right? Because this was in addition to the rest of your life, right? So you are in school, you're working, you have a personal life, and then on top of that, you had this tremendous responsibility, right? So you know that it was a very selective process, and we were hoping for a lot of commitment. So I wonder whether if each one of you could tell us briefly about the most challenging and the most rewarding moment from the time that you got selected for the academy, even maybe before the interview process, to today, to when you are now presenting, So a few months with us, right? I mean, a lot of months with us. You also, something that we have not said, so for the audience, is that we wanted to make sure that the students had the competencies for enough about policy, and so that they were well positioned to be part of the state team. So we enrolled them sooner than the launching of the policy academy. So Jessica, for example, came with some knowledge of policy, but some of the students didn't have any. So we developed an entire different curriculum for them prior to really launching the policy academy. So going back into history, memory lane, most challenging and most rewarding moment of this experience, Josh?
Yeah, so for me, I think the most challenging thing I think it was being like adjusting to like such fast-paced things that we were doing, and then also incorporating that into like my life essentially now, like you had mentioned, like between school and working full-time and things like that. Like that was a big challenge, and trying to figure out what I was going to do as far as time frame, um, and participating in some of the things. But as most of you know, like I would log on when I was in the car, like driving to where else I was going to interact and have these conversations with everybody or attend my meetings. Um, Also, I think another challenge for me was I'm a very social person. So I think not having all of us in the same state or the same area at all times was very kind of challenging for me, because I really thrive off of interactions with people. And when we finally met up in Chicago, like that was like the time of my life. Like I really enjoyed it. I loved it the most. Um, Most rewarding, I think, would be collaborating with my peers, and other fellows within the program, and then hearing diverse perspectives, because we're like you had mentioned before, we're all students, but we all come from different universities, we all come from different backgrounds. So seeing how I connected with other individuals outside of my university, because again, my university, not everyone looks like me on my university. So seeing the work that's being done, or the work that has been done already moving forward with professionals in the community, it was really rewarding to see. So that's my perspective on it. I really enjoyed it.
Great, thank you, Josh. Jessica, most challenging and most rewarding moment?
Okay. I would say that the most challenging part of this experience was understanding my scope as a student. I was surrounded by a team of experts who have done this process over and over. Me, on the other hand, like I only took one class in policy, and then I received training from Luz and Cristina for the past couple of months. But I wasn't truly, I felt that I wasn't truly prepared for what was to come. But that was not true at all, because when I did work with the team over time, I did feel empowered to, express my ideas and do some research and facilitate discussions between different individuals. So yeah, I would say that at first understanding my scope was a little challenging, but over time that didn't end up being the case. And for the most rewarding part, yeah, I was meeting the students in person in March in Chicago, like seeing all those faces. I wanted to talk about that a little bit later when we were okay. Now I would just talk about another rewarding part. Another rewarding part of this experience was also like the final 2 weeks before the final presentation, when we like all sat down and talked about the action plan for this policy reenactment. So technically, like our role kind of concluded the moment that we finalized our 2 policy recommendations, but it was really important to kind of create a transition plan from planning to implementation. And so those 2 weeks were focused on that. We identified potential funding sources. We identified personnel within the Wisconsin Department of Health Services on to engage, and also we considered which departments we would need to pitch this idea in order to move it forward. So just being part of that discussion and that forward thinking, solutions oriented process was really rewarding.
Great. Thank you. So as you know, we are hoping to recreate this again, right, in 2027, and we really want a lot of students to at least show an interest and to apply for that, right? So I hope, hopefully this question is the right one, right? So if someone asks, right, if one of the students it's like, oh, I really listened to your webinar and it was like awesome, whatever, why? Because it seems like you had a good experience, right? I'm hoping, not 100%, but it was challenging, right? Okay, so I think that the question is the appropriate one. So if someone were to ask you, what would you recommend for behavioral public health students, a policy experience like the one you just had, why would you recommend it? What is different? Josh?
I would recommend it because for me, it bridges the gap between theory and like real world action. Behavioral health students or public health students, like we often just focus on like program level interventions. So basically just at the forefront of things, like not really diving deeper into what the main issue is versus what we can see or what we've researched. So I think with this, I would recommend it because it allowed me to actually speak with the states. I get to see what is actually going on within the states or what people are actually dealing with or having issues with or what people need advice or someone to advocate for them within their community for. I think that it gave me like a deeper appreciation for how systems influence health outcomes and what we can do to build off of that. But again, as a public health student, we only base it off of what we can see, but not what we're actually living the experience or learning from others.
Mm-hmm. Thank you, Josh. Jessica?
Along the same lines, I would recommend it because this experience allows students to grow, like academically and in a personal level. As students, we were challenged to refine our thinking and navigate an ambiguous environment and just work through something that is real, like a real policy problem. And that served to be one of the best experiences I've had during my educational years. Also, just being surrounded by people who come from similar backgrounds. Like I'm a first gen, I am Latina myself. Just really made me feel like I belonged. And it reinforced that I am an asset and not an outlier.
Wow, you're making me emotional. You too, okay? All right, let's lighten this up a little bit. So, okay, my last question before some of the comments, and we open it to the audience. Hopefully they'll have some questions for you, but also for Rachel and Travis. So, in 10 years, because I'm convinced this is going to happen, when you are leaders in behavioral health, because you are, the 10 of you are going to be, what would be the memory? Like 10 years, you're going to have a lot of health experiences, right? But in 10 years, when you're leaders, what would be the memory that would make you smile when remembering your participation in our Policy Academy? Okay, yeah, I'm giving you a second. You're already smiling, you know. I see Travis is smiling too, you know. Okay, because I'm going to ask you to yeah, I don't but okay, we're going to get it started, because then I am going to ask that to all of the other Rachel and Travis, so get ready. And if there are any other members of the Academy online, please. Josh, what will make you smile?
I think, again, going back to the in-person meetings that we had, we would be working on this, all day long, and then in the evening time, we would come together to hang out and kind of just be away from working at on policies and looking at different state things. But no matter what we did, it always still came back to looking at policies, and that would be the discussion at the forefront. And it would just be we can't get away from this. And so it would just make everyone laugh. It's a good time. It was just so much fun getting to be with everybody. And looking at everyone's success, as they're going forward, what they're doing with graduation or with their, careers moving forward after graduation, even offering guidance to, I think, what was it? Frank was he our only undergrad? Pushing Frank on what school he should go to for his master's and just things like that, just having fun with all of it. So the whole program, it was a good time.
Great. Jessica, what will make you smile in 10 years?
Definitely exactly what Josh said. Every time we met in person, so the first time that we met in Chicago was definitely one for the books. We all kind of bonded in a very natural, meaningful way, and pretty instantly too, which was really nice because I was very nervous. But yeah, I would say every time that we met in person felt really nice, because I've most of the year we just saw each other through the screens. So just having that real life connection just really made this the best experience.
Mm-hmm. Rachel, now we are finishing the students, and before we go and put our last slide, which will be the QR for the evaluation, and then people can ask, anything that will make you smile through this experience?
I mean, I really honestly have to tell you, our experience with the students, both the ones that were, obviously the ones that were specific to Georgia, but in person in September, I cannot stress to these students how impressed those of us that have been in the fields for way longer than we care to admit, how much y'all being there and what you brought to the table meant to us. It was so refreshing and so impressive. And honestly, to see the future of mental health and things like this Policy Academy and this next generation coming in, you're getting old when you start talking about the next generation, but that's a whole nother conversation. But it just gave me so much hope for where our mental health world and this field is going. And y'all blessed us. We all still talk about y'all and how amazing you are when we get together. At least I know we do still in Georgia, all of us that got to meet you and stuff like that. And so just thank you so much for being a part of this, because I'm sure there were other things that y'all could have done. And y'all chose to do this very meaningful work. And, honestly, Christina, they still make me smile. And I still brag on them every time I have an opportunity to. So
good. Excellent. Thank you, Rachel. Travis, what will make you smile in 10 years from now about this experience?
Well, first of all, it made me smile now, because when you said 10 years from now, I just saw retired across my head. I thought, I'm retired, but no, really, truly, I think what would make me smile, and I think I get kind of giddy just feeling just like what Rachel said too, is when I turn on the news or I see some read some journal, turn on the news, something, and I'm seeing folks like Jessica and Josh who are making a difference in our nation. That's what I'm expecting to see, and that's probably what's going to make me smile, or anyone, between now and then, who's going to be like, well, while my time at the Behavioral Health Center of Excellence, and they start their sentence with that, I think it'll make me smile because I will get to reflect that 10 years ago I was a part of that. And like these students, such a valuable information that they gained, but that they also taught. And I think even I left, our in-person meeting a few months ago, knowing, that a lot of the students that I got to meet and talk with are going to be that next level generation that is going to make a difference. And I think it's just wonderful. So that's a great question. And thank you for asking that, Christina.
Yeah, no, sure. You were talking about retirement, and I am getting so close to that. Actually, so when you get to that after 40 years, you start thinking, what are going to be the things that down the road, when I'm not doing this, are going to make me smile. And I realized that there's not that many in 40 years, believe it or not, because, my work has been so eclectic, but there's a few that will always remain with me. And I have to say that this Policy Academy and each one of you will make me smile, because I remember the first time we met or approached you to be part of the Academy. And, there were all of this, yeah, we know we have to do that, but how are we going to do it? And so trying to get the buy-in of everyone was a challenge, because of what it was already said. There was also political change. There are other priorities. So you had said, Rachel, that you were blessed. I think that we at the center were the ones who were blessed, clearly, because we couldn't have wished for a better team than the one that was representing the Policy Academy 2025. So if I could ask Paola to bring up the last slide, so that people have the opportunity to look at the QR codes and scan them, and please fill them up, because that's important. And so while you're doing that, we still have a few more minutes, and I wanted to ask if anyone in the questions and answers section, or probably in the questions and answers, so we can read it, has any comments, any questions, any reflections. Any of those of you who are part or were part of the Policy Academy? I see Allison Weber there saying, I have been so impressed by these interns throughout this academy, the Wisconsin DHS, so appreciate the opportunity to be part of it and be able to work with Jessica and Frank as our interns. They are amazing. Thank you. Thank you, Allison. So as I reflect, and as I said, I'm almost on my way out now, getting into that, retirement talk. It's important to look back. What was the intention when we got this Policy Academy going? There's not a precedent of that with what we use, as far as bringing all of those communities, and in addition to the dedication and the excellence of everyone involved, I think that there were unintentional consequences, right? As I had mentioned to Travis before, I mean, the fact that one of our concerns was what is there for the supporting states. But I think that you, Travis, and I think that I would dare to say that the same thing applies for the other four that were in the supporting states role. They were also learning about things that were important, that maybe people were looking at it directly, or potential solutions that had been worked through your interaction with them and the students, that may bring in your own states to address some of those challenges in a different way. But to me, I think that the thing that will make me smile it's that we have created a community of knowledge, a community of knowledge across the United States. I mean, right now We had 10 students coming in from different states with different experiences. But you heard Jessica, how as they were looking at implementation, they were looking at experiences of other states that were not necessarily part of the academy. So we have created now this community of knowledge. Everyone who's been involved in this policy academy will continue being in touch. And I am convinced about that. It's even to the point where some of you have even said to the students, oh, we are going to need people, we may have positions open for you, So to me, it's that community, it's that passion, is that commitment. It also has allowed to the states that were more in the receiving end with the technical assistance to be able to focus on something that has always been very important, but with, like Rachel said, you sometimes don't have the bandwidth for that. You know that this is important, but it takes a dedicated person, human resources to do that, or a certain level of expertise, because there are all of these competing situations. The fact that they were, we were the connectors at the Center of Excellence, and any question or any issue that the states in general had, we will make sure that we could put people in touch. So for me, those are probably the most valuable ones. Clearly, of course, the policies, and the audience have heard how all of the states already have an implementation plan. They're already moving forward, including Travis, right? In New Mexico, it's already having a plan, taking from some of the discussions that she's been a participant of. So I personally, from where I stand after all these 40 years, this has been one of the most meaningful and closer to my heart initiatives that I have participated. I really want to congratulate everyone that has been a part of that. Also, the leadership of the Hispanic Latino Center, Behavioral Health Center of Excellence, for their support. And if there are no more questions or comments, I think I'm going to give you back 4 minutes. Please don't forget to fill out this evaluation. These are really, really important. Remember, you are going to have the presentation, the PDF of the presentation, the recording. And if you think that this was interesting and if you learned something, I want to encourage you to share it. Share it with others. Let's just start enhancing the community of knowledge, just focusing on behavioral health in general, but specifically on our Latino communities. And follow those students on LinkedIn, because one day you will say, oh my God, I remember that student. Look who he or she is now. And remember what I'm telling you. Thank you very much. Thank you, all of you, all of the presenters, all of the participants. Please don't be a stranger. Continue working with us. And if any of you who are not part of the Policy Academy wants to learn more about the Policy Academy, and just please don't hesitate to reach us to our Center of Excellence. You have a great late afternoon and evening, and thank you very much for your attendance. Goodbye. Have a great rest of the day.